All right, well, good afternoon, everyone. Thanks for joining us again on this Good Friday. I am pleased to talk about this topic. Well, not talk, to listen to this topic by one of our very own experts, Ms. Gretchen Wartman, who works with us at the National Minority Equality Forum. I think she has the most tenure at the organization right now, and she has been in the healthcare space for some time. And if you ever want to know anything on healthcare, especially in pricing and modeling and patient care and patient access to care, she's the best person for that job. I just sing her praises and all the work that she's done, that she continues to do. And I'm going to turn it over to her to lead this very informative panel. So Gretchen, I'll turn it over to you.
Thank you, Brandon. And good afternoon to everyone. For those who may have missed Brandon's opening remarks, my name is Gretchen Wartman. I'm Vice President for Policy and Program of the National Minority Equality Forum, and I am Director of the Forum's Institute for Equity in Health Policy and Practice. In this webinar, we're continuing our discussions with thought leaders in the public and private sectors regarding reimagining the healthcare system in a manner that inculcates the principles of equity and reduction of patient risk as prime drivers. I am joined this morning by two panelists who will brief us on the leadership work being undertaken by the National Institutes of Health to address the need for robust representation of all population groups within both the participant and the researcher cohorts in American health services research. Our first speaker will be Dr. Martin Mendoza. Dr. Mendoza is the Director of Health Equity for the NIH All of Us Research Program. Dr. Mendoza's experience includes serving as Director of the HHS Office of Minority Health's Division of Policy and Data, and the lead for extramural research in the FDA Office of Minority Health and Health Equity. Dr. Mendoza received his doctorate in cancer biology from Johns Hopkins University. Our concluding speaker, Ms. Victoria Rucker, is the program manager for the NIH Unite initiative, which was established to address structural racism and promote racial and ethnic equity within the National Institutes of Health and throughout the larger biomedical research enterprise. Prior to joining Unite, Ms. Rucker served as the acting manager of the Management Analysis and Policy Group in the NIH Center for Information Technology and filled several positions in the NIH Office of Equity, Diversity, and Inclusion. Ms. Rucker has a Master of Public Administration from Seattle University. As our speakers present, please feel free to enter your questions into the Q&A box. The Q&A box, not the chat box. Questions were also submitted during the registration process, and of course, I have a few of my own. We will attempt to answer as many of our questions as possible. However, we will also include contact information for Dr. Mendoza and Ms. Rucker in the chat box so that you can follow up with them separately after this event. Dr. Mendoza, the podium is yours.
Thank you, Gretchen. Let me get up my slides here. Share my screen. Can folks see my screen?
I
Right.
can.
Great. Okay, so let's get started. So, excuse me, just having a little control issues here. So good afternoon, everyone, and thank you, Ms. Warren, for that lovely introduction. I'm Martin Mendoza, and as Gretchen mentioned, I serve as the Director of Health Equity for the All of Us Research Program at the National Institutes of Health. I wanted to take a moment to thank the National Minority Equality Forum for their invitation, and I'm just so delighted for the opportunity to be here with my fellow panelists, Ms. Victoria Rucker, and most importantly, to speak with all of you about the All of Us Research Program. Well, I'd like to start out today with recognizing there may be some tuning in who are not familiar with the All of Us Research Program. So to answer that question, what is the All of Us Research Program? All of Us is an effort spearheaded by the National Institutes of Health, and it is the cornerstone of the Precision Medicine Initiative that was launched in January of 2015. All of Us is working to bring together 1 million or more volunteers from across the United States to donate health information for research. Among many other things, researchers may be able to use the information we collect to identify steps that we can all take to stay healthy, to find health conditions early when they are often most treatable, to better understand disparities in our communities, and also to develop more effective, personalized, and precise treatments that are based on us as unique individuals. As Dr. Francis Collins, director of the NIH, has previously stated, All of Us is among the most ambitious research efforts that our nation has ever undertaken. So the All of Us mission is simple, but bold, and that is to accelerate health research and medical breakthroughs to enable individualized prevention, treatment, and care for all of us. We aim to create a new model research based on building and maintaining relationships with participants for decades. We want to deliver a valuable, rich resource and repository of data that will be broadly accessible and safe. And finally, we will do what it takes to catalyze a robust ecosystem of researchers to use this national resource. Over the past few years, we have been focused on our participants, ensuring we are enrolling and retaining participants from diverse backgrounds. We've also been working on getting the data out to researchers via the public data browser and the researcher workbench, which launched in beta phase in May of last year. While we continue to work on these objectives, we have also turned our attention to the researcher ecosystem. In particular, we must ensure that researchers from underrepresented communities can utilize the program's resources. Many of you have already shared ideas with us about how we can help level the playing field by increasing the pipeline of diverse researchers and increasing capacity at institutions that have diverse researchers, and I encourage you to please continue to send us your ideas. So to dive into the program a little more, as you can imagine, too often, healthcare is one size fits all. Treatments meant for the average patient may not work well for individual people. Healthcare providers may find it difficult to coordinate care among specialists or to access all of a patient's health information. Researchers may spend lots of time and resources creating new databases for every study. The All of Us Research Program is working to improve healthcare through research. Unlike research studies that focus on one disease or group of people, All of Us is building a diverse database that can inform thousands of studies on a variety of health conditions. And so to that end, I want to spend just another minute talking about the specific ways that All of Us is unique. First, All of Us was founded with the core values that participation is open to all, that the rich diversity of the United States is one of our greatest strengths, and that our participants walk with us as our partners. Participant input is not only welcomed, but it is a cornerstone for every aspect of the program. Participants will have access to the data they share and information about all research projects that use All of Us data. And next, All of Us welcomes participants of all backgrounds and walks of life, from all regions of the country, whether they are healthy or sick, including those people who haven't taken part in or have been left out of health research before. All of Us is building one of the largest health databases of its kind, including many types of data from surveys to electronic health records to biospecimens. We plan to make this resource as accessible as possible while still protecting the privacy of our participants. So where is the program with enrollment? As of November 2021, more than 430,000 people have enrolled in the program, with 306,000 plus completing all the initial steps of the program's protocol. This includes over 324,000 biosamples, as well as over 250,000 electronic health records. So let's talk diversity. As I mentioned earlier, All of Us plans to build a cohort of 1 million individuals with an emphasis on including communities that historically have been underrepresented in biomedical research, which you may see abbreviated as UBR. This includes racial and ethnic minorities, older adults, and in the future children, sexual and gender minorities, people with disabilities, residents of rural and non-metropolitan areas, and people with inadequate access to healthcare, low income, or low educational attainment. The program's goal is to have 75% of participants be from UBR communities and 50% be racial ethnic minorities. The program is currently, as of November 2021, achieving these targets. Now let's talk about the researchers that will be accessing this data. And so that I really want to stress that we will only be successful if we ensure diversity of both our participant cohort as well as our researcher cohort. We want to engage diverse communities, not only as participants, but as researchers who are on our data platform, bringing perspectives informed by a broad range of expertise and experiences. In particular, we are committed to creating a demographically diverse research cohort who can promote ethical use of our data and generate outcomes that return greatest value to our participant communities. We are committed to encouraging students and early career investigators that will bring fresh, creative perspectives and propel innovative research outcomes. And only by ensuring access for researchers from all institutions and organization types so that we are truly building an equitable resource. So to summarize some of the key points I have shared with you today, participation in All of Us is open to all. All of us participants are our partners and reflect the rich diversity of the United States. The program is 100% committed to transparency, and all of us participants have access to their information. On the research side, data is accessed broadly for research purposes while maintaining only the highest levels of security and privacy. Again, thank you for taking the time to join today's webinar, and please do not hesitate to reach out to us with any questions about the program. I'd like to pass it back now to Ms. Wartman.
Thank you, Dr. Mendoza. Ms. Rucker?
Thank you, Ms. Wartman, and thank you, Dr. Mendoza, my colleague from NIH, for a wonderful presentation. I always learn from you every time we have the opportunity to talk. So I don't have slides for you today. I'm just going to have a conversation. And it actually starts about 1.5 years ago. So in June of 2020, as many of us were doing, watching TV, seeing the images of the tragic images of George Floyd's murder being televised across our nation and the world for that matter. And we were in the midst of a pandemic. I was watching TV with my son, watching the news, and he was 8 at that time. He's 9 now, and he'll tell you, I'm almost 10. So, but he's a big boy. But at 8, he says to me, we're watching the news, and he looks at me and says, Mom, I think we have 2 pandemics in this country. And I said, son, tell me more. He said, well, we have COVID-19. I said, yeah. He's like, and And I also think racism is a pandemic. This is an 8-year-old. And he said to me, this was June 2020, he said to me, "Mom, maybe the next president will do something about that." Little did I know that indeed things were happening at the NIH to address my 8-year-old's questions and concerns about the country that we lived in and the world that we lived in, for that matter. The NIH was having those same conversations under the veil of darkness in some ways, because we were bound by an executive order from September of 2020 during the Trump administration that put a halt on all, it was titled Combating Race and Sex Stereotyping, put a halt on all of these kinds of efforts that were looking at structural racism. But the NIH, being the NIH, was grappling with the same questions my son was grappling with. And they quickly understood that our role as a health agency in looking at what was happening in our country with regard to COVID and the disparities we saw, particularly impacting Black, Brown, and Native communities in our country. What happened with George Floyd, there was a sense of urgency at the NIH that we needed to do something about it. From our perspective, what could we do? What was happening in the world was directly related to health outcomes. And that's what we're all about. So they called a number of different meetings with our institute and center directors to identify some of those initial issues that we needed to confront. There were 2 self-assembled groups that reached out to Dr. Francis Collins, our NIH director. He will be stepping down as NIH director at the end of this year, as I'm sure many of you have heard. But those 2 groups were ACRE, or 8 Changes for Racial Equity, was a group, 8, and then CRE, so ACRE. And then the African American and Black scientists sat down and had very candid conversations with our director, said enough is enough. We as a health organization are bound to do something. And they listened, and I give much credit to our leadership for that. There was a commitment at that time that they were going to, not they, we as an agency, were going to address structural racism and to not allow that moment to pass. And so that's what was happening in 2020, even under this executive order that bounded us from doing anything. There were the initial issues that were identified were ensuring that biomedical research and the administrative system that supports it, that's more of my role. So everybody who has a role in our industry is devoid of hostility grounded in race, sex, and other federally protected characteristics. And the second thing, and this is most important, in my opinion, to what Unite is about, we had to make a strong commitment to delineate elements that may perpetuate structural racism in biomedical research, both within the NIH community and in the extramural community, that leads to a lack of personnel inclusiveness, equity, and diversity. So that was happening. This is all happening under, again, veil of darkness, all these conversations, and they pulled together this group that represents all 27 institutes and centers across the NIH, representing all levels of the organization. So we have senior leaders, and these are all employees of the NIH, senior leaders, middle managers, entry-level employees, all working to have conversations about what we can do in 5 particular areas. And one, we needed to understand what was happening. We needed to listen and learn. So we held listening sessions and we put out an RFI, and many of you may, on this call today, may have responded to that. I will also tell you that there are some additional listening sessions that are coming up. So I will get into those in a moment, but there are ways to lend your voice to what we are trying to accomplish. There's a committee that's focused on health equity, health disparities, and minority health. And the research, much to what Dr. Mendoza was talking about, how do we enhance the research in those areas so that we can address what we've seen with regard to the disparities that were so prominent as a result of COVID-19. But that's not the only area where we have disparities, we know that, but it brought into sharp focus what we were dealing with in our country. Another committee was looking at our internal workforce. There's a fourth committee looking at and ensuring that we are being transparent. We're telling people what we're doing. We are looking at the data. We're making data available. And then we have a fifth committee that's focused on our extramural workforce and the work that we're doing outside of the NIH. So some of the things that we've accomplished through the Unite initiative is, one, it was very clear from the groups that met with Dr. Collins that we had to make an announcement. We had to say we were committed to this work. Well, we couldn't quite make that announcement under the executive order we were, working under and under the hush of that executive order. My son said, maybe the next president will do something about it. And when President Biden was sworn in January 20th, he indeed released an executive order that same day on advancing racial equity and support for underserved communities through the federal government. And within that executive order, revoked the order that we were bound under, that we couldn't say anything. So that was revoked. The other, and that executive order of President Biden's, I would encourage you all to look at, because that's specifically how federal agencies are being tasked with committing to ensuring racial equity in the work that they're doing. That happened. And then Unite was able to, we're Unite, this is what we do. And Dr. Collins, to his credit, on March 1st, made a public commitment apologizing to anyone who was impacted by racism in this industry. We recognize that there is a gap in funding, particularly impacting African Americans, Native Americans. This was identified as the Ginther gap back in 2013. So we're aggressively working to close that gap. We have a common fund that's committed up to $60 million focused on transformative health disparities research and reducing health disparities and inequities. We've implemented that. We have several FOAs that are looking at, we have a number of funding opportunities that are looking at structural racism and discrimination and the impact of that on health disparities and inequities. And we've also created a way to make data available to you. You can go right now to our Office of Extramural Research and see who's being funded based on race, gender, and ethnicity. You can look at that data. You can go to our intramural research program. You can look at the data there and looking at our principal investigators. You can look at our NIH workforce. So we're trying to respond to the call, but we have lots of work to still do. One thing I will leave you with is that one thing that we have acknowledged and are steadily working towards is how do we improve the diversity of scientists within the NIH. We understand that the more diverse we are as an organization, the more we reflect the diversity of our American population, how that translates into health equity, because people are bringing their own research interests to the work that we're doing. And so the last thing I will say is I'm encouraged by the work of the NIH and the acknowledgement that in order to truly lessen the gap in our health equity, and to achieve health equity, I should say, and to truly live out our mission, the NIH has a very strong and noble mission that impacts health in the lives of everyone. Every one of you are touched by the National Institutes of Health. But in order to do that and realize that for all people, we must confront structural racism and identify and dismantle any disparities that may prevent us from doing the work that we are committed to doing. I am proud today that I can tell my son, DJ, they heard you. They're listening. We have a new president who is trying to do something about that. And the NIH has hearkened to your call to address the two pandemics you identified last year, racism and COVID-19. So with that, I will turn it back to you, Ms. Wartman.
Thank you. And thank you, Ms. Rucker and Dr. Mendoza, for such informative presentations. Before we begin the Q&A session, I would ask that you make sure that we have links to the information that you referenced, the sites that you referenced, Ms. Rucker, and I think Dr. Mendoza has given us a link to the All of Us research program. But I think it would also be helpful to have a link to the executive order that President Biden signed. I know some people may have seen it, others may not, but to include a link in the chat box would be great, because that executive order not only triggered activity at the National Institutes of Health, but across the entire federal landscape. And that includes not just federal employees, but federal contractors and subcontractors. And it is so far reaching that I think it's essential that all are aware of what the president has called for in terms of being proactive, in terms of identifying structural and systemic racism and other biases in the business of the federal government, and then taking steps to redress it. I thought it was extraordinarily important. So the first question is going to combine, I think, a couple of issues and some that have been asked by our audience as well, and it giving you both of you an opportunity to expand upon the actions you're taking to address the concrete actions you're taking to address the core value of diversity through your programs. Some specific examples. Questions are being asked about whether training programs are being funded in colleges and universities that have research capacity, but and are minority serving institutions and have historically been disenfranchised by the manner in which funds are allocated in the research universe. There are some questions from individuals who are or have an interest in becoming individual researchers and principal investigators, and whether either All of Us or NIH through the Unite initiative are creating training and certification programs to enable those individuals to be recognized by both the public and private sectors as investigators who warrant inclusion in research. And then I would add to that, if it's a question you can answer, how you may be stimulating the private sector to be more proactive in constructively engaging with those underrepresented institutions and researchers going forward. So that was a really simple question. I'm going to ask Dr. Mendoza to answer first, and then Ms. Rucker. Pick any part of it.
Thank you, Ms. Wartman.
Thank you.
As I talked about in my presentation, diversity is one of the core values of All of Us. And, you know, the program is asking a lot of people to join the program. And so the participants are from different races, ethnicities, age groups, regions of the country. They're diverse in gender identity, sexual orientation, socioeconomic status, education, disability, and health status. And so when you think about it, diversity in a research program is important for several reasons. First, where we live, how we live, and our background can all affect our health. And many groups of people have been left out of research in the past. So this means that researchers, they know less about their health. And so by studying data from a diverse group of people, researchers can learn more about what makes people sick or keeps them healthy. And what we learn today can lead to better healthcare for us in the future. And when we look back through history, health research has left out many different groups of people, and because they weren't included in the research, they may not have gotten to benefit from the results. And so all of us has really tried to learn from that history. And so we want to be sure that we do things right, so that we earn trust and so that many different groups of people can join. We will tell you what we are doing. We are going to share our results, and we're going to do our absolute best to protect your data. And so you're absolutely right, Ms. Wartman. It's one thing to write down core values, and it's another to live them. So here's what we're doing. So for all of us, I can tell you one example is that participants are our partners. As I mentioned during my presentation, the program has participants involved in almost every piece of program development. We have participants who sit on governance committees, participate in our internal meetings. They're a part of local All of Us community advisory boards, among many other ways. And they're really such an amazing soundboard and really keep us true to what we want to be. Another example is our work around trust and transparency. We have meaningful partnerships with more than 40 community partners who conduct awareness and educational opportunities across the US. They're really helping us to create safe spaces for hard conversations on topics such as historical transgressions and the value of research. So I'm going to stop there, I could go on for more for this, but I want to give Ms. Rucker a chance to chime in here.
Thank you, Dr. Mendoza. So there are a number of things that we're looking at within the Unite initiative that are, and I will say, let me just say this really loudly. We work really closely with all of us too. We have people who are within the Unite initiative on all of us. And that's one of the unique things about the Unite initiative is that this is an NIH-wide initiative where we are leveraging the talent and the work that's been happening in this area from across the NIH. So I hear Dr. Mendoza, I'm like, oh yes, there's so much of what he's saying is so similar to some of the things we're saying too, but that's because those voices are present. And that's why it's so important to include those voices from across our agency, especially those voices and leveraging voices that aren't always at the table. And so that is something I want to reemphasize that. If we are acknowledging, and I believe our workforce demographics is in there, we're acknowledging that our workforce, especially senior leadership at the NIH, is very homogeneous. How do we make sure that those voices that represent others, other experiences and perspectives are at the table? And so that's what's also unique about Unite is that we are bringing people who represent all different types of experiences. They're bringing their questions and their thoughts to the work that we're doing. So I did want to make that acknowledgement. But one of the things that we're working to do right now is expanding our Distinguished Scholars Program. And we currently have a Distinguished Scholars Program that seeks to recruit researchers for underrepresented groups. And these are for our IRP investigator positions. And after I'm done with answering this question, I'll get the link and put it into the chat for Keiko to send out. But we're looking to expand that to our senior investigators. While we have seen a lot of really promising practices from the Distinguished Scholars Program, we still acknowledge, and this goes to my earlier comments, that our senior investigators are very homogeneous. And so expanding that, we're doing the same program, but expanding it to our senior investigators that are hired with tenure. So these are investigators that are hired with tenure, utilizing the promising practices we've seen in our Distinguished Scholars Program and applying it to a senior investigators program is one of the things that we are initiating in order to ensure those voices are included. So that's one big thing I will point to. The other things that I kind of already addressed some of this, but the research that we're doing, the Common Fund initiatives that are specifically focused on transformative research related to health equity and health equity and minority health, and the commitment that we've made up to $60 million. And the other thing I want to point to that I don't want to downplay, but we talked about one of our committees, the U committee, which is dedicated to understanding stakeholder experiences through listening and learning. And that's where your voices are so important. As we're moving forward, thank you, Keiko, you're amazing. She put the link in there, so thank you. You are ahead of me, I appreciate that. This is where we're going to turn to you. If you've already responded to our RFI that was out last, I believe it went out in March and was up for about a month. We are still working through that data, but we are also going to, as I mentioned earlier, continue our listening sessions, and we are working to update our website with when those listening sessions will be. And and these are all external facing. We did internal listening sessions, but the listening sessions that are coming up in December and in February are specifically focused on our external stakeholders. And that includes members of minority serving institutions. It includes our faith-based communities. We really want to hear the information or the perspectives of everyone who's touched by the work of the NIH and how structural racism has impacted them and what we should be doing moving forward and things we should be thinking about. So I would encourage you, once they're up, again, we're working on updating our website to include when those are and how to register. I will make sure you will have that link so you can register at your convenience. But that is one way that you can get directly involved with the Unite initiative. It is currently consists of all NIH employees because we're trying to understand our own workforce and what we need to do. But there are ways that you can volunteer and make sure that your voices are included as we're moving forward.
Thank you. We've got I have a number of questions still that speak to essentially how NIH is going to measure success, the degree to which you may have already been successful or not, either through the Unite initiative or All of Us research program, in bringing about the kind of change that's been discussed for decades in this country as is an essential component of a responsive research delivery and financing system. But I'm going to ask the question a little differently, which is not only how is NIH going to encourage the behavior change, but how is it willing to use the authority it has to essentially incentivize behavior change by no longer enabling certain behaviors in the research enterprise? And that one of the questions we received had to do with perhaps NIH sponsoring peer-reviewed journals that would address some of the challenges that either researchers of color or researchers who are working on issues that are of particular interest for participants of color, for patients of color, to get that research published. And it occurs to me that one can create new journals, but one can also communicate to the journals where federal employees publish that they should be more inclusive of those researchers and that subject matter, or we might find alternative outlets for that kind of research. And I know I didn't prepare either Dr. Mendoza or Ms. Rucker for this question, but it's been coming up to us for 10 years as we've convened roundtables and key opinion leaders around these issues. And the question becomes, at what point does the leverage that resides within NIH? How is it used in the same way that Dr. Collins used it when he made the decision to no longer participate on conference panels that were not inclusive of women? That same kind of decision-making, and I know Dr. Collins is leaving, that same kind of influence can be brought to bear on this topic. So I guess, Ms. Rucker, you first, and then Dr. Mendoza, if you want to speak to it as well.
That's a very well taken point. And one of the things that I want to expand on when you were talking about Dr. Collins saying he was no longer going to sit on what he called manels, M-A-N-E-S, right? They're men only panels, is that he expanded that to also include panels where there were no people of color. So I do want to acknowledge that he made that declaration, and then he followed it with, and I will no longer sit on all white panels. So, and that you're right, that that influence is so important. And we have a responsibility to influence where we can and when we can and how we can within the constricts, I will say, of the law. There are some things we simply cannot do, and people want us to do more, but we cannot because we are a federal agency. So we do have some restrictions that we have to abide by. With regard to peer-reviewed journals, I know that there has been some conversations around what you just recommended, Ms. Wartman, around what can we do as the NIH to ensure that more diverse perspectives are being published in journals. I know that there are, I want to give you accurate information. So I'm expecting a message. Oh, there it is. And I have a file for you, but I was able to get some more information in my chat. They have met, the NIH has met with the Nature Journal editors and provided them access to the Chief Officer of Scientific Workforce Diversity search tool to enhance recruitment of more diverse reviewers. Dr. Lawrence Tabak, Dr. Alfred Johnson, Ms. Treva Hopkins-LeBoy, and Dr. Marie Bernard. And I'll explain who those people are in a moment. Dr. Tabak is the Principal Deputy Director of the NIH. So he is the second in command of the NIH right now. Dr. Alfred Johnson is our Deputy Director of Management. Ms. Treva Hopkins-LeBoy is the acting director of our Office of Equity, Diversity, and Inclusion. And Dr. Marie A. Bernard is the Chief Officer for Scientific Workforce Diversity, just published a commentary in Nature Medicine, and that will be coming out this week, I believe, in a couple of days. So stay tuned for that, the 14th. So that, oh, sorry, next week, it'll be coming out on Sunday, I believe. That also speaks to this issue. And there are a number of others. Our Dr. Michelle Evans, who sits on the NEJM editorial board, and Dr. Bernard also participated in an expert consultation session with JAMA, the Journal for JAMA. I'm blanking on what the letters mean. I know it, but my mind went blank. So to your point, Ms. Wartman, those conversations are happening right now, and they're happening with some of those journals that have such influence in this area. So yes, to answer that question, it's happening, and I will, if I'm able to share this file with you, the commentator. Oh, sorry, it was actually published today. I will send the commentary that was published that I mentioned, that was published in Nature Medicine about starting their diversity series. So that's happening.
Thank you. Excellent. Dr. Mendoza, did you want to add anything to
Yes,
Ms. Rucker's comments?
Yes, thanks. So I just wanted to really echo Ms. Rucker. As she correctly stated, there are certain limitations as a federal agency that we must abide by. But in terms of using our influence, I think one way that all of us is really trying to do that is by setting an example for the research community. around health equity and inclusion, and making that very, very clear to the community that this is a cornerstone, if not the cornerstone for our program, and that we are 100% committed to this. And it's not because it's just a feel-good thing to do. We're also very confident that we will show that having that diverse data set of both participants and researchers will be a major part of leading to these future medical breakthroughs. And so from the scientific and this medical perspective, it's going to be a huge asset to medicine and to science. And we think that will be a critical way that we show how the commitment to diversity and equity and inclusion is such an important part of this program.
Thank you. So as we move towards closing, I'm going to ask one more question. What I'm the concern is being expressed by the audience that now that Dr. Collins, and that's my language, has become so critical as a leader in both the Unite program and the All of Us research program. The question is whether Unite and All of Us will continue, whether they are rooted in the structure of NIH in such a way that they will continue after, they will be able to continue after Dr. Collins leaves at the end of this year, I think it is. And as you're talking, and I'd ask both of you to sort of articulate the sort of your take-home message to the audience. And so I would say combine the question about sort of the post Francis Collins world at NIH with your take-home message for the audience. And I'll start with Dr. Mendoza and then move to Ms. Rucker.
Thanks, Ms. Wartman. So I would say, stating the obvious that it's difficult to predict the future, but I personally feel that I don't see Unite or All of Us going anywhere. I see great support among not just from Dr. Collins, but from all throughout NIH, from all leadership. And so I am confident that folks are seeing the value of these initiatives, and that that they will and that Dr. Collins has set them up in such a way that they are now part of the NIH fabric as they should be. And so really what my take-home message is for the All of Us research program is something that I alluded to earlier, and that's that diversity, equity, and inclusion are really at the core of this program, and that we are striving to make every effort that they are front and center for every major decision. And that includes obviously with our enrollment, as well as building that diverse research community, because without diversity, equity, inclusion, our programs just, they won't work. So we need to make sure that we have this at the table, and that we are 100% committed to it.
So before Ms. Rucker answers, Dr. Mendoza, if you could include in your answer sort of as a concrete example of what All of Us does, how All of Us contributed to accessing data and informing COVID-19 research initiatives, I'm assuming in a way that facilitated more inclusion and diversity in those research cohorts.
Yep, absolutely. So, really, it's a great question. So back in late September, just a little over a month or two ago, All of Us released additional data on people's experiences with the COVID-19 pandemic through our researcher workbench. And so the new data came from 3 different sources: surveys, electronic health records, and wearable devices like Fitbits. And so what this means is that all of us researchers can now access curated data provided by nearly 330,000 participants who represent a wide range of age, races, gender identities, sexual orientations, and socioeconomic levels. And so the new data release includes results from the All of Us COVID-19 Participant Experience, so COPE for short, that survey. And so the COPE survey, if you haven't heard of it, it explored participants' experiences during the COVID-19 pandemic, and it was administered 3 times during the winter of 2020 through 21. So new responses from more than 35,000 participants, those actually augmented their early responses from 64,000 participants that are already in the researcher workbench. And so the initial COPE survey data from summer 2020 were released in the December 2020 data release. And the data now offer a longitudinal view over more than 8 months. So participants shared insights about life, symptoms, and how they manage mentally and emotionally. And so we also had more than 11,600 participants link their personal Fitbit data with their All of Us accounts. And this provided the first data collected during the pandemic to come from people using wearables. We have COVID-19 EHR data that's now available. And then data around vaccination status will be released in future data expansions. So together, this combined data from wearables, EHRs, and the longitudinal COPE survey provides a unique data set for addressing important questions related to pandemic. And so together, they have, again, this more comprehensive picture of that period of time. And we can start to look at how staying at home, how that affected the mental health and physical activities of our participants, and correlate it with Fitbit data to see, for example, if their physical activity increased or decreased. So lots of really neat ways to look at the data and to start to really understand what was going on during COVID.
So then I would say that sort of linking that back to All of Us post Dr. Francis Collins, those All of Us participants who have those Fitbits, the challenge now not only is to continue to recruit so that we can, so that you can get to your 1 million target, but also to retain those participants for, is it 10 years at least?
Well, so we're actually looking to maintain a decades-long relationship with our participant partners. We want to be there. We want to be there for them and with them, throughout the whole lifespan. So retention, as you just pointed out, is absolutely critical to the program. It's not just enrollment is obviously the initial step, but our program is highly it's very highly important that we maintain a commitment and that retention to our participants, and especially those that are underrepresented by medical research.
Thank you. Ms. Rucker.
So that is something that with regard to what happens when Dr. Collins moves on from his director position. One thing that I am hopeful about is one that the leadership that we have in place right now that's supporting Unite includes our principal deputy director, Dr. Tabek, I mentioned, our deputy director of management, Dr. Alfred Johnson, our chief officer for scientific workforce diversity, Dr. Marie Bernard. Those are the 3 co-chairs of the Unite initiative. And so I anticipate the initiative continuing to move forward with what we are working to do. The other thing that is also encouraging is that, as I mentioned earlier, we have representation from all 27 institutes and centers and OD offices. And when I say OD, that means the Office of the Director, which is not technically an institute or a center, but there's the Office of the Director, and we have a number of employees representing that group on the initiative as well. So the more that you make it a part of what we do, and the more we change how we do business. And as we are looking at structures and revamping those structures to ensure that we are enhancing diverse perspectives, that becomes a part, interwoven into the work that we do as the NIH. And so I anticipate, even though Dr. Collins will be stepping down, the continuity of Unite will continue on. We'll keep moving forward. But we are also looking to ensure that we get as much as we can get done now. We have to strike while the iron is hot. We can't wait. It is imperative that we move on what we can do and do it now. But the more that we make it about, this is how we do business. This is what's good for science. I think that helps to resolve that question, because it shouldn't matter who's in that director position. It's just how we do, this is what we are going to do and how we are going to do work as an agency, as the NIH.
And your take-home message?
Oh, my take-home message. I am not a scientist. I'm the first one to say that. I'm the program manager. I have a Master of Public Administration, as you mentioned. When I decided to join the federal government, I had a really rich experience working all over the country, specifically focused on not health outcomes, but educational outcomes for low-income kids of color. And that has been my life's work. And I came to the NIH, and I work in HR. I do workforce management. That's my job. So what does that have to do with this? It has everything to do with this. One of the things that I want you all to know is that even though I'm not a scientist, I see this work, my contribution to this work, and a number of our non-scientists too as well, to the work that we're doing as an organization in this space requires all voices, right? And that's why I encouraged all of you to participate in those listening sessions, then we will get that information out to you. But it also requires those of us who are behind the science to step up and use our voices too. It requires a full commitment by the entire agency to move this forward. And so what I will tell you, and the take-home message for you, is that there is so much energy and motivation by people who are volunteering their time. People are not getting paid to do this work. They are volunteering their time in addition to their full-time jobs in the labs, in the, if they're working in our facilities, whatever their work is, they're doing this on top of. And I would encourage you to allow that to motivate you and inspire you, that there are people who are willing to go above and beyond every day in order to ensure that this thing that we're talking about and how it impacts so many people, and this thing is that structural racism within the biomedical research enterprise, that there are so many people committed to dismantling that in our organization. And I anticipate that you all eventually will see some of those outcomes. You asked about measuring success. One of the measures for me is that you all feel that work. You feel it, that people, everyday people are feeling the work that we're doing every day. So that would be my take-home message to you, is that we are in it. We've rolled our sleeves up. You see my sleeves are up, literally and figuratively, to address this.
Oh, thank you. And I'll close then. Thank you, Dr. Mendoza and Mr. Rucker, I think, for a very open and honest conversation. As we move forward in the National Minority Quality Forum to pursue these conversations about reimagining healthcare, what we also plan to do is to move the healthcare conversation beyond the Department of Health and Human Services, because we know that other agencies of the federal government have programs that are health programs, or have programs that influence our ability to be healthy. And what we will do is contact the Department of Agriculture and the Environmental Protection Agency and others, because it would be great to hear that a Unite-like initiative has been undertaken in those agencies, as well as HHS, the Department of Education, the Department of Defense. And so we will put that on our schedule for future webinars in 2022 and beyond. And again, thank you to Dr. Mendoza and Ms. Rucker and Brandon, if you are still there. I don't know if you wanted to make a few closing remarks. Brandon's not there. Then our thanks to the audience, and it's at 1 o'clock. Thank you so much, and we hope to see you next time. Bye-bye.